So today we will start with the small intestine, and first of all we will read about the normal structure. Anatomically, the small bowel has a length of 550 to 650 centimeters, which includes the duodenum, jejunum, and ileum, and tends to become narrower throughout its course. Histologically, there are four layers: serosa, muscularis propria. The serosa is the outer covering of the small bowel, which is complete except for a part of the duodenum. In muscularis propria, it is composed of two layers of smooth muscle tissue, outer thinner longitudinal and inner thicker circular layer. These muscles are functionally important for peristalsis. Submucosa, it is composed of loose fibrous tissue with blood vessels and lectins in it. It contains a gangliated plexus, mesos plexus having fewer and smaller cells than the Auerbach's plexus. Then comes the mucosa, which consists of glandular epithelium overlying the lamina propria, composed of loose connective tissue and contains phagocytic cells and abundance of lymphoid cells, which are also known as pairs, patches in the ileum, and plasma cells. It is supported externally by a thin layer of smooth muscle fibers, muscularis mucosae. The mucous membrane is thrown into folds or plici, which are more in the jejunum and less in the ileum. The absorptive surface is further increased by the intestinal villi. The villi are actually finger-like or leaf-like projections which contain three types of cells. First, simple columnar cells which perform absorptive function due to the presence of fresh water consisting of large number of microvilli. Second is goblet cells, which are mucus secreting cells and are interspersed between the columnar cells. Third ones are the endocrine cells, which are scattered in the villi as well as are widely distributed throughout the GI tract. These cells have various synonyms as under. They are also known as Pulchishki cells or the enterochromaffin cells due to their resemblance to chromaffin cells of the adrenal medulla. Argentophin cells in the cytoplasmic granules stain positively with silver salts by reduction reaction, therefore known as argentophin cells. Endocrine cells, as these specialized cells are considered to be a part of Apert cell system, which is amine content, amine precursor uptake, and decarboxylation. Apert cells are considered to be endodermal in origin, while previously they were thought to be neural crest derivative. So here we can see that the duodenum contains distinctively branched Brunner's glands present in the submucosa and going up to muscularis mucosae. The deeper layer of the mucosa of the small intestine elsewhere contains intestinal glands of crypts of Leperkin. They are lined by columnar cells, goblet cells, endocrine cells, and Paneth cells. Paneth cells are normally exclusively found in the small intestine and occasionally in the cecum. These cells are characterized by the presence of supranuclear granules, which are rich in lysozyme. The blood supply of the whole of small intestine, except the first part of the duodenum, is by the superior mesenteric artery, which supplies blood by mesenteric arterial arteries and the straight arteries. The main function of the small intestine, as we all know, are digestion and absorption, so that ultimately nutrients passing into the bloodstream are utilized by the cells in metabolism. Then we come to the congenital anomalies, and here we study about Meckel's diverticulum. So it is the most common congenital anomaly of the GI tract, occurring in almost 2% of population. It is more common in males, and it is commonly situated at the antemesenteric border of the ileum, about 1 meter above the ileocecal wall. Like other true diverticulum, Meckel's diverticulum is an outpouching containing all the layers of the intestinal wall and their normal orientation. It is almost always lined by small intestinal type of epithelium. Rarely, it may contain islands of gastric mucosa and ectopic pancreatic tissue. Embryologic origin of Meckel's diverticulum is from incomplete obliteration of VIT duct, that is vitellointestinal duct. Other anomalies which can result from the remnants of VIT duct are vitelline sinus and vitelline cyst. The common complications of Meckel's diverticulum are perforation, hemorrhage, and diverticulitis. In addition to congenital Meckel's diverticulum, acquired diverticula also occur in the small intestine. These are commonly multiple, frequently located at the mesenteric border, and are sometimes associated with malabsorption. So here we can see an outpouch growth, which is Meckel's diverticulum, and it is at the entry-mesenteric border, and it is about like this is the gross, and here we can see that the lumen contains the necrotic debris. Other anomalies, there are a few uncommon anomalies of the small intestine. Intestinal atresia, which is a congenital absence of urine, most commonly affecting the ileum or duodenum. The proximal segment is a blind end which is separated from distal segment freely, or two segments are joined by a fibrous cord. Intestinal stenosis is congenital narrowing of the lumen affecting a segment of the small intestine. Intestinal segment above the level of obstruction is dilated and that below it is collapsed. Intestinal malrotation is the development abnormality of the midgut, that is the portion of intestine between the duodenum lecture and middle of transverse colon. Due to failure of normal rotation of midgut, the following consequences can occur: exomphalos, displacement of the cecum, and mobile cecum. So now we will study about the intestinal obstruction. Now we will see the intestinal obstruction. It is the obstruction of the GI tract and it can occur at any level, but the small intestine is most often involved because of its relatively narrow lumen. Collectively, hernias, intestinal adhesions, intersusception, and volvulus account for 80% of mechanical obstructions, while tumors and infarction account for most of the remainder. The clinical manifestations of intestinal obstruction include abdominal pain and distension, vomiting, and constipation. Surgical intervention is usually required in cases involving mechanical obstruction or severe infarction. Volvulus and adhesions between bowel lobes are here illustrated that I'll show you figure out. So the conditions which interfere with the propulsion of contents in the small intestine are basically considered under the heading of intestinal obstruction, and the causes of intestinal obstruction can be classified under the following three broad groups. First is the mechanical obstruction. It can occur as a result of the following causes: internal obstruction, which can be intramural or intraluminal, and the causes may be inflammatory strictures like Crohn's disease, congenital stenosis, atresia, imperforate anus, tumors, meconium and mucoviscosis, roundworms, gallstones, picolets, cotton bodies, ulceration induced by potassium chloride tablets prescribed to counter hyperkalemia. And then there can be external compression, which may include peritoneal adhesions and bands, strangulated hernias, intersusception volvulus, and intra-abdominal tumors. Now, the intersusception, it is the telescoping of a segment of intestine into the segment below due to peristalsis. The telescope segment is called the intersusceptum and more receiving segment is called the intersuscipiens. The condition occurs more commonly in infants and young children, more often in the ileocecal region when the portion of ileum invaginates into the ascending colon without affecting the position of the ileocecal nerve. Less common forms are ileal and colic intersusception. In children, the cause is usually not known, though enlargement of the lymphoid tissue in the terminal ileum has been suggested by some. In the case of adults, the usually causes are foreign bodies and tumors. The main complications of intersusception are intestinal obstruction, function, gangrene, perforation, and peritonitis. Here we can see that this part is the intersusceptum, whereas the part receiving intersusceptum is intersuscipiens, and there are congested vessels, and this is the impacted vessel. So now the volvulus, it is the twisting of loop of intestine of colon itself through an degree or more. This leads to obstruction of the intestine, and as well as cutting off of the blood supply to the affected lobe. The usual causes are bands and adhesions and non-mesenteric attachment. The condition is more common in the sigmoid colon than the bowel. So this is the volvulus and this is intersusception. First one is the intestinal obstruction, and like this is the herniation basically of the segment, like into the another segment. This is adhesions, this is volvulus, and this is intersusception. Hernia, it is a protrusion of portion of a viscus through an abnormal opening in the wall of its natural cavity. External hernia is the protrusion of the bowel through a defect or weakness in the peritoneum. Internal hernia is the term applied for herniation that is not present on the external surface. Two major factors involved in the formation of a hernia as a term. First of all, there is local weakness which will be congenital, like acne umbilicus, inguinal and femoral canals, and in cervical scars called as incisional hernia. Then there can be increased intra-abdominal pressure that is produced by coughing, straining, and exertion. So inguinal hernias are more common, followed in increasing frequency by femoral and umbilical hernias. Inguinal hernias may be of two types, direct and indirect. So direct is when hernia passes immediate to the inferior epigastric artery and it appears through the external abdominal ring. Indirect is when it follows the inguinal canal lateral to the inferior epigastric artery. When the contents of hernia, such as loop of intestine, can be returned to the abdominal cavity, it is called as reducible. When it is not possible to reduce hernia due to large contents or due to additions in the hormonal side, it is also referred to as irreducible. When the blood flow in the hernial sac is obstructed, it results in a strangulated hernia. Obstruction to the venous drainage and arterial supply may result in infarction or gangrene of the affected of intestine. The gross and microscopic appearance of a strangulated intestine is the same as that of infarction of intestine. Now, the Hirschsprung disease. It occurs in approximately 1 of 5,000 live births and stems from the congenital defect in pulmonary innervation. It may be isolated or occur in combination with other developmental abnormalities. It is more common in males but tends to be more severe in females. Siblings are at increased risk for development of Hirschsprung disease. Patients typically present as neonates with failure to pass meconium in the immediate postnatal period followed by obstructive constipation. The major threats to life are endocarditis, fluid and electrolyte disturbances, perforation, and peritonitis. Morphology. The Hirschsprung disease always affects the rectum with the length of the additional involved segments varies. Most cases are limited to the rectum and sigmoid colon, but severe cases can involve the entire colon. The aganglionic region may have a grossly normal or contracted appearance, while the normally innervated proximal colon may undergo progressive dilatation as a result of functional distal obstruction. Diagnosis is made by demonstrating the absence of ganglion cells in the affected segment. So here we can see the surgical section of the aganglionic segment with anastomosis of the normal colon to the rectum is effective, although it may take years for patients to attain normal bowel function and continence. This is Hirschsprung disease. A is preoperative varium minima study showing constricted rectum at the bottom and dilated sigmoid colon. Ganglion cells were absent in the rectum but present in the sigmoid colon. Corresponding intraoperative appearance of the dilated sigmoid colon. So, the pathogenesis, the enteric neuronal plexus develops from neural crest cells that migrate into the body. Embryogenesis. Hirschsprung disease, also known as congenital aganglionic melanoma, results when the normal migration of neural crest cells from cecum to rectum is disrupted. This produces a distal intestinal segment that lacks both the Meissner submucosal plexus and the Auerbach myotonic plexus aganglionosis, and thus fails to develop coordinated peristaltic contractions. Mutations in the receptor tyrosine kinase RET account for a majority of familial cases and approximately 15% of sporadic cases. Mutations in other genes, including disease-modifying genes as well as environmental factors, must also be involved. Vascular disorders of bowel. The largest portion of the GI tract is supplied by the celiac, superior mesenteric, and the inferior mesenteric arteries. As they approach the intestinal wall, the superior and inferior mesenteric arteries fan out to form the mesenteric arteries. Interconnections between arteries as well as collateral supplies from the proximal celiac and distal pudendal and celiac circulations make it possible for the small intestinal and colon to tolerate slowly progressive loss of the blood supply from one artery. By contrast, acute compromise of any major vessel can lead to infarction. Ischemic bowel disease. Ischemic damage to the bowel can range from mucosal infarction extending no deeper than the vascularis mucosa to neural infarction of mucosa and submucosa to neural infarction involving all the three layers of the wall. While mucosal or neural infarctions often are secondary to acute or chronic hypoperfusion, transpleural infarction is generally caused by acute vascular obstruction. Important causes of acute arterial obstruction include severe atherosclerosis, aortic aneurysm, hypercoagulation states, oral contraceptive use, and ambulization. This is a schematic diagram to show the three types of ischemic bowel disease depending upon the extent of involvement. This is mural infarction, this is transmural, this involves all the layers, and this is only the mucosa. The one which includes the mucosa up till the muscularis propria is mural infarction. So the other risk factors for arterial obstruction are intestinal hypoperfusion, which can also be associated with cardiac failure, shock, dehydration, or vasoconstrictive drugs. Systemic vasculitis and other causes include invasive neoplasms, cirrhosis, portal hypertension, trauma, or abdominal masses that compress the portal drainage. Pathogenesis, the severity of vascular compromise time frame during which it develops, and vessels affected are the major variables that determine severity of ischemic bowel disease. Initial intestinal responses to ischemia occur in two phases. The initial hypoxic injury occurs at the onset of vascular compromise, and although some damage occurs, intestinal epithelial cells are relatively resistant to transient hypoxia. The second phase, the perfusion injury, is initiated by restoration of the blood supply and is associated with the greatest damage. Two aspects of intestinal vascular anatomy may also contribute to the distribution of ischemic damage: watershed zones, and the second one is patterns of intestinal microvessels. So, the watershed zones refers to the intestinal segments at the end of their respective arterial supplies that are particularly susceptible to ischemia. These zones include the splenic flexure, where the superior and inferior mesenteric arterial circulations terminate, and to a lesser extent the sigmoid colon and rectum, where inferior mesenteric, pudendal, and iliac arterial circulations, and generalized hypotension or hypoxemia can therefore cause localized injury at these sites, and ischemic disease should be considered in the differential diagnosis for focal colitis of the splenic flexure or rectosigmoid colon. The patterns of intestinal microvessels: intestinal capillaries run alongside the glands, to surface with the hairpin. Hairpin turn at the surface to empty into the post-capillary venules. This configuration leaves the surface epithelium particularly vulnerable to ischemic injury. The surface epithelial atrophy, or even necrosis and epithelial slowing with normal or hyperproliferative cracks, constitutes a morphologic signature of ischemic intestinal disease. Despite the increased susceptibility of watershed zones, mucosal and mural infarction may involve any level of the gut from stomach to anus. Involvement is frequently segmental and patchy, and the mucosa is usually spread out. The bowel wall is thickened by edema that may involve the mucosa or extend into the mucosa and muscularis propria. So now the microscopic examination of ischemic intestine. It demonstrates atrophy or slowing of surface epithelium. By contrast, curves may be hyperproliferative, inflammatory infiltrates are initially absent in acute ischemia, but neutrophils are recruited within hours of deperfusion. Chronic ischemia is accompanied by fibrous scarring of the lamina propria and uncommonly structure formation. In acute cases of ischemic damage, bacterial superinfection and enterotoxin release will induce pseudomembrane formation that can resemble Clostridium difficile associated pseudomembranous pruritus. Ischemia. Here in figure A, we can see characteristic attenuated and partially detached villus epithelium and acute general ischemia. And in B, there is chronic colonic ischemia with atrophic surface epithelium and fibrotic lamina propria. Clinical features: ischemic bowel disease tends to occur in older adults with coexisting cardiac or vascular disease. Acute transmural infarction typically manifests with sudden severe abdominal pain and tenderness, sometimes accompanied by nausea, vomiting, bradycardia, or grossly melanotic stool. This presentation will progress to shock and vascular collapse within hours as a result of blood loss. Peristaltic sounds diminish or disappear, and muscular spasm creates board-like rigidity of the abdominal wall. Because these physical signs overlap with those of other abdominal emergencies, including acute appendicitis, perforated ulcer, and acute cholecystitis, the diagnosis of intestinal obstruction may be delayed or missed with disastrous consequences. The overall progression of ischemic enteritis depends on the underlying cause and severity of injury. Mucosal and neural infarctions by themselves may not be fatal. However, these will progress to more extensive transmural infarction if the vascular supply is not restored by correction of the insult or in chronic disease by development of adequate collateral supplies. Chronic ischemia may masquerade as inflammatory bowel disease with episodes of bloody diarrhea and interspersed with periods of healing. Now, cytomegalovirus CMV infection, it causes ischemic GI disease as a consequence of the viral tropism or an infection of endocrine cells. CMV infection can be a complication of immunosuppressive therapy. Radiation enterocolitis occurs when the GI tract is irradiated. Necrotizing enterocolitis is an idiopathic disorder of the small and large intestines that can result in transperineal necrosis. It is the most common acquired GI emergency of neonates, particularly those who are premature or low birth weight. Its occurrence is often associated with initiation of bleeding. Angiodysplasia is characterized by malforms of mucosal and mucosal blood vessels, occurs most often in the cephalopolyp and usually presents after the sixth decade of life. Hemorrhoids, they are the dilated anal and perianal collateral vessels that connect the portal and uh, cavernous systems to relieve elevated venous pressure within the hemorrhoid plexus. Thus, although hemorrhoids are less common than esophageal varices, the pathogenesis of these lesions is similar. They are common, affecting about 5% of the general population. Common predisposing factors include constipation and associated straining, which increase intra-abdominal and venous pressures. Venous stresses of pregnancy and portal hypertension. Collateral vessels within the inferior hemorrhoidal plexus are located below the anorectal line and termed as external hemorrhoids, while those that result from dilatation of the superior hemorrhoidal plexus within the distal rectum are referred to as internal hemorrhoids. On histological examination, hemorrhoids consist of thin wall dilated submucosal vessels beneath anal or rectal mucosa. These vessels are subjected to trauma which leads to rectal bleeding. In addition, they can become thrombosed and inflamed. Hemorrhoids often manifest with pain and rectal bleeding, particularly bright red blood seen on toilet tissue. Hemorrhoids also may develop as a result of portal hypertension, where the implications are more obvious. Hemorrhoidal bleeding generally is not a medical emergency. Treatment options include sclerotherapy, development ligation, and infrared coagulation. In severe cases, hemorrhoids may be removed surgically by hemorrhoidectomy. Diarrheal disease. Diarrhea is defined as an increase in stool mass, frequency of fluidity typical to amounts greater than 200 grams per day. In severe cases, the stool volume can exceed 14 liters per day and without fluid resuscitation result in death. Worldwide diarrheal diseases account for greater than 7 lakhs of deaths of children under 5 years of age, making them the second leading cause of death in this group. Painful, bloody, small volume diarrhea is known as dysentery. Diarrhea is a common symptom of many intestinal diseases, including root due to infection, inflammation, ischemia, malabsorption, and nutritional deficiency. It can be classified into four major categories: secretory, osmotic, malabsorptive, and exudative. Secretory is characterized by isotopic stool and pulses during fasting. Osmotic is such that occur with lactase deficiency and is due to osmotic forces exerted by unabsorbed luminal solutes. The diarrheal fluid is at least 50 milliosmoles more concentrated than plasma, and the condition abates with fasting. Malabsorptive diarrhea is caused by inadequate nutrient absorption and is associated with steatorrhea and is relieved by fasting. Exudative diarrhea is due to inflammatory disease and is characterized by purulent bloody stools that continue during fasting. Malabsorptive diarrhea. Now, the malabsorption manifests most commonly as chronic diarrhea and is characterized by defective absorption of fat and water soluble vitamins, proteins, carbohydrates, electrolytes, minerals, and water. Chronic malabsorption causes weight loss, anorexia, abdominal distension, gallbladder and muscle wasting. A hallmark of malabsorption is steatorrhea, characterized by excessive fecal fat and bulky, frothy, greasy, yellow, clay colored stools. The chronic malabsorptive disorders most commonly encountered in Western countries are pancreatic insufficiency, celiac disease, and Crohn's disease, environmental enteric dysfunction, or environmental enteropathy, which is the malabsorptive component, is pervasive in some communities within developing countries. Malabsorption results from disturbance in at least one of the four phases of nutrient absorption, intraluminal digestion, in which proteins, carbohydrates, and fats are broken into the absorbable forms, terminal digestion, which involves the hydrolysis of carbohydrates and peptides by dicyclases and peptidases, respectively, in the fresh wall of the small intestine, transepithelial transport, in which nutrients, fluid, and electrolytes are transported across and processed within the small intestinal epithelium, the lymphatic transport of absorbed lipids. Celiac disease, also known as celiac, is gluten sensitive enteropathy, immune mediated enteropathy, triggered by the ingestion of gluten containing cereals such as wheat, rye, or barley in genetically predisposed individuals in countries whose populations consist predominantly of whites of European ancestry. Celiac disease is a common disorder with an estimated prevalence of 0.5 to 1%. The primary treatment for celiac disease is a gluten-free diet, which results in symptomatic improvement for most patients. Pathogenesis. Celiac disease is an intestinal immune reaction to gluten, the major storage protein of wheat and similar grains. Gluten is digested by luminal and fresh water enzymes into amino acids and peptides, including a 33 amino acid gliadin peptide that is resistant to degradation by gastropancreatic and small intestinal proteases. Gliadin is deamidated by tissue transglutaminase and then able to interact with HLA DQ2 or HLA DQ8 on antigen presenting cells and be presented to CD4 plus T cells. These T cells in lamina propria produce cytokines that likely contribute to the tissue damage and characteristic mucosal histopathology. Androcytes that have been induced by various stressors to express certain MIC-A. The damage caused by these immune mechanisms may increase the movement of gliadin peptidases across the epithelium, which are then deamidated by tissue transglutaminase, thus perpetuating the cycle of disease. While nearly all individuals eat grain and are exposed to gluten and gliadin, most do not develop disease. Most do not develop celiac disease. Thus, most factors determine whether disease develops among these. HLA proteins seem to be critical since almost all individuals with celiac disease carry the class 2 HLA-DQ2 or HLA-DQ8 alleles. There is also an association of celiac disease with other immune diseases, including type 1 diabetes, thyroiditis, and Sjogren's syndrome. So, here there are a number of alterations which may be present in the celiac disease, like varying degrees of um, villus atrophy, increased number of intraepithelial lymphocytes, then epithelial proliferation with crypt elongation, and uh, both innate and adaptive immune mechanisms are involved in the tissue responses to gliadin. Clinical features: pediatric celiac disease, which affects male and female children equally, may manifest with classic symptoms typically between 6 and 24 months of age, with irritability, abdominal distension, anorexia, diarrhea, failure to thrive, weight loss, or muscle wasting. Children with non-classic symptoms tend to present at older ages with complaints of abdominal pain, nausea, vomiting, bloating, or constipation. A characteristic pruritic blistering skin lesion, dermatitis herpetiformis, is also present in as many as 10% of patients, and the incidence of lymphocytic gastritis and lymphocytic colitis is increased as well. Morphology: biopsy specimens from the Second portion of duodenum or proximal region which are exposed to the highest concentrations of dietary gluten are generally diagnostic in celiac disease. Histopathology is characterized by increased number of T lymphocytes with intraepithelial lymphocytosis, crypt hyperplasia, and villus atrophy. This loss of mucosal and fresh water surface area lead to villus atrophy, probably accounts for the malabsorption. Other histological features of celiac disease can include increased number of plasma cells, mast cells, and eosinophils, especially within the upper part of the laminar propria. The combination of histological and cytologic findings is therefore the most specific for diagnosis of celiac disease. An antibody response follows. This includes production of antibodies against tissue transglutaminase, deaminated gliadin, and perhaps as a result of cross-reactive opioids. Anti-endomycin antibodies which can be diagnostically useful. They may also be used to monitor disease as titers typically fall after 3 to 6 months of gluten-free diet. Here we can see in advanced cases of celiac disease which show complete loss of villi or total villus atrophy, and there is dense plasma cell infiltrates in the laminar propria. Then infiltration of the surface epithelium by T lymphocytes which can be recognized by the densely stained nuclei. In adults, celiac disease manifests most commonly between 30 to 60 years of age. However, many cases escape clinical attention for extended periods because of atypical presentation. Some patients have silent celiac disease defined as positive serology and atrophy without symptoms or latent celiac disease. Symptomatic adult celiac disease is often associated with anemia due to iron deficiency and less commonly between B12 and folate deficiency. The idea is limited but non-invasive cytological tests are generally performed before biopsy. The most sensitive tests are the presence of IgE antibodies to tissue transglutaminase antibodies or the deaminated gliadin. Anti-endomycin antibodies are highly specific but less sensitive than other antibodies. The most common celiac disease associated cancer is enteropathy associated T-cell lymphoma and aggressive tumor of intraepithelial T lymphocytes. So it is however important to recognize that failure to adhere to a gluten-free diet is the most common cause of recurrent symptoms, and that most individuals with celiac disease do well with dietary restrictions, and they die of unrelated causes.